Yeah. Good morning, everybody. So we'll be talking about the ERG, that is visual electrophysiology. So there'll be a keynote address by Dr. Peter. He'll be talking about the ent- entopic images of the retina. So we are there to hear you, sir. Please come over.
Thank you. Good morning. So yes, mine is not about electrophysiology, but about entoptic images. And no, I don't know how to. So these, of course, are visual effects that are. These, of course, are visual effects that originate from the eye itself as light interacts with the ocular structures, making internal processes or features visible. How do I move it along? There's the. So often overlooked, they're important because patients are naturally curious. Some have pathologic implications, and particularly in the past, some could be used as tests of visual function. So the blue field endoscopic phenomena is where one sees fast-moving bright spots near fixation, particularly when looking at a uniform field that is blue, like the sky. Most likely these spots represent the leukocytes within the perifoveal capillaries, and their presence implies a healthy foveal circulation. Another is visual phosphenes, which are streaks of light, flashes or patterns seen either in the dark or as a result of eye rubbing. The ones associated with quick eye movements are a sheaf-like pattern when the eyes are moved quickly from side to side when you're completely dark adapted. And I guess none of you are suffering from jet lag, but if you woke up early this morning, you could try it out, as I did. Pressure phosphenes can also occur. The common one is due to eye rubbing, which is a feature, of course, of some blinding congenital eye conditions as the baby tries to get some visual stimulation. But even blowing your nose can give mechanical pressure. And of course, Moore's lightning streaks. The temporal lightning-like flashes seen predominantly in the dark or when one moves the eyes quickly can be a precursor to PVD, which of course is not always so benign. You'll note many of these are named after people in the 19th century who first described them. So Purkinje's tree is named after another 19th century Czech, and it's an image of your own retinal vasculature. If you close your eye and get a torch and rub underneath it, illuminating your eye, you'll be able to see your own retinal circulation. Maxwell is better known for his work on electromagnetism as a physicist, but he described a blue spot in the center of fixation due to the macular pigment. You can also pick it up if you look at a field of blue spots, and you'll notice that the one you're looking at is bluer than the other ones. I hope you agree. And of course, this is due to the macular pigment. Macular pigment also features in Heidinger's brushes, yellow brushes around fixation in blue or plain polarized light. It can be disturbed by foveal disease. And the Stiles-Crawford effect. So in the 1920s in England, when automobile accidents were increasing, Walter Stiles and Breena Crawford wanted to measure the effect of light intensity on pupil size. And they found that luminance of the pupil is not proportional to the area of the pupil. Luminance on the retina is not proportional to the area of the pupil, but rather it decreases for light entering near the edge of the pupil, probably because light is coming obliquely through those photoreceptors and so therefore getting subject to interference. Also, if you're myopic or hyperopic, the maximal illumination changes and becomes asymmetric on the retina. But there's still more to discover, not just in the 19th century. In 2022, it's shown that the mitochondria and photoreceptors can act as microlenses to deliver light with an angular dependence, and this could be part of the explanation of the effect. So there is still more to find out about entoptic images. Now the one is blue arcs of the retina. Classically, it was said when you are staring in at a fire in a dark room, so what people used to do 100 years ago. Perhaps it's set off by activity in the nerve fibre layers, setting off the cones underneath it. And there are many types of after images and many causes, too many to go through, but all are lingering visual impressions, either a positive or a negative after image, depending on whether they have the same or complementary colours. Some are indicative of pathology. Here's a couple. So if you look at the waterfall for a minute and then look away, you'll still have motion artifact. Or if you look at one of the coloured dots on that girl's face, when you look away, you'll see a negative after image. But you have to look at it for maybe 30 seconds or a minute, preferably, which we probably haven't got time for. And then, of course, in the dark, it's never completely dark, thanks to spontaneous neural activity. Another one, of course, is floaters, which, of course, can have many causes, often seen against a uniform background. And mentioning floaters, it's important to remember that sinister conditions also cause entoptic images or images that people may confuse with entoptic images. So retinal traction and mechanical pressure can cause phosphines, and transmission dysfunctions, for instance in serous detachments, can cause to moving lights. Thus, retinal vein occlusions can give you flickering, as can PIC, as can the paraneoplastic carcinoma and melanoma-associated retinopathies from abnormal retinal stimulation. Whereas uveal melanoma, which causes serous detachments, which causes traction on the retina, and which eventually invades the retina, can cause a whole multitude of different images. Starbursts are most commonly due to optical imperfections such as cataract, while tiny flickering points of light can occur with retinal or neurological disease. Well, of course, the latter is not an entoptic phenomenon, rather a photopsia. And abnormal colour perception, just to round that off, is also due to many causes. So persistent positive visual phenomena, in contrast to entoptic images, are usually neurological in origin. Perhaps the most common neurologic cause of persistent flashing lights that could be confused for an entoptic image is migraine, which of course often features a visual aura, the classic aura being the fortification spectrum, although heat haze images and scintillations are also possible, but they're longer lasting generally. And of course migraine can come from the retina too when it's monocular. And it's been shown to be associated with retinal artery spasm, as per the above image, which was taken during a rare observation during a retinal migraine. Another distinction between entoptic images and other images that are more neurological is those that come from higher up in the visual pathways tend to be more complicated. Think of sort of the basic white flashes versus little green men maybe you might get in psychoses. Psychoses are probably the highest, right? So psychotic hallucinations, i.e. images and thoughts that people believe and act on, are not actually that uncommon and obviously are cortical in origin rather than entoptic. The other group of people that we might commonly see getting visual hallucinations are those with low vision resulting in Charles-Bonnet syndrome. These are also cortical in origin, but it's important to remember these people are not schizophrenic and reassure them about it since they're aware that it's not real. Thank you.
Yeah, altogether it was a very neat topic to us. Fantastic topic, and you covered so many things. It used to come to us, but we never thought about it, how it comes, and very nicely done.
The two things one thing that bugs me in particular is when registrars say this person's got flashes and they never go into a further and they just instantly get hold of the vitreoretinal surgeon thinking it's a VR problem. Many times it's not.
Yeah.
Excuse me,
So that's
I love
one
you.
thing that I think
हम लोग तीनों का लो।
makes me like this topic.
अरे भेज देना।
Beautiful. Vibhuti, your topic is introduction. Yeah.
तो फर्स्ट उसी को करने दीजिए.
Introduction of visual electrophysiology लगा दीजिए, Dr. Vibhuti.
क्या?
Dr. Vibhuti.
बहुत अच्छा.
Akka.
बहुत अच्छा. मैं भेज दूँगा. डोंट वरी. कहाँ हो?
Let's start.
Yeah, please start.
Yeah. Good morning, everyone. I must thank AIOS for giving us this opportunity to talk about this very important diagnostic tool that we have. And I must thank our chief instructor, Dr. BP Kashyap sir, for giving me this opportunity to be a part of this instruction course. So I'll be introducing the electrophysiology so that we get the basic information, and the subsequent co-instructors will be giving you the details. We have so many diagnostic methods. We use indirect ophthalmoscopy, we use 90-day examination, OCT, retina. They all give us the anatomical information about the eye. Fundus fluorescein angiography gives us the vascular details, and visual field gives us the functional details of the eye, but usually it manifests late and it's not very specific. While electrophysiology is early and specific. It gives us information of the diseases at in the very early stage, and it's very specific. And it has been standardized by the International Society for Clinical Electrophysiology of Vision. So why do we need electrophysiology tests? It is basically to localize the problem in visual pathway. We get symptoms, history, family history, clinical examination, but they all have their limitations. Like night blindness may have many other causes apart from RP. An absolutely normal looking retina may have no vision or disproportionate loss of vision. Retinal pigment abnormality may not match the visual disturbance that they have. Now, who are the candidates? All those patients with symptoms suggestive of known neurological or other ophthalmological diseases which require confirmation of the diagnosis, like retinitis pigmentosa, Best disease, multiple sclerosis, etc. If they have an unexplained visual loss, including medical legal problems and defects associated with psychiatric disturbances and mental and physical handicap. It is very, very useful in pediatric neuroophthalmic practice, and where media opacities prevent other clinical examinations from establishing a diagnosis, like cataract, corneal opacity, and vitreous hemorrhage. It can be used to monitor health of retina in patients receiving medications which could be retinotoxic or neurotoxic, SCQ, ethambutol, tamoxifen, phenothiazine, etc. Then in patients who have inherited visual disorders, and it detects the disease or in carrier states like in RP and cone dystrophy. It provides a quantitative assessment of the progress of an eye disease and assessment of retinal and optic nerve function following trauma. So what are the indications? Who are the patients who need referral, who need these tests? In cases of inherited retinal degeneration, glaucoma, we have a whole lot of, like in retinal degeneration, we do perform full field ERG, multifocal ERG, pattern ERG. In glaucoma, pattern ERG is helpful. In ocular siderosis, full field ERG. In retinal detachment, full field ERG and VEP. In multiple sclerosis, VEP. Inflammatory ocular disease, full field ERG, multifocal ERG. In retinal ischemic diseases, we do full field ERG and multifocal ERG. And in endophthalmitis, full field ERG and VEP. In case of unexplained visual loss, there's a failure to read the chart without any abnormality, and visual behavior is normal. If the visual behavior is normal, then full field ERG, multifocal ERG, pattern ERG and VEP is very useful. And in post-traumatic visual impairment, pattern ERG, multifocal ERG and VEP is done. So basically, what is electrophysiology? What it does is it records the membrane resting potential and the changes that occurs after light stimulation. There is a transmembrane movement of ions in retinal cells, mainly the sodium and potassium. It makes the cell hyperpolarized, that is more negative to the extracellular space than in the dark. Like in ECG, the heart is beating, so we get a stimulus from within. But in ERG, the cells are at resting condition and requires light stimulation for the changes to happen at resting potential. There's a list of electrophysiology tests: the EOG, scotopic ERG, photopic ERG, pattern ERG, multifocal ERG, pattern VEP, and flash VEP. There are some other tests also which will be coming, which we will be using, like ERG on-off response, S-cone ERG, multi-channel VEP, sweep VEP, and albino VEP. The experiments are going on, and most likely they will also be added to the main list. So different tests are done to detect different abnormalities of different areas. Like EOG, it tells us about the RPE, resting potential. The pattern EEG tells us about the gross macula function. Scotopic ERG about the rod function. Photopic ERG, the cone function. Multifocal ERG tells us about the macular photoreceptors. Pattern VEP about the macular ganglion cells. And flash VEP about the visual cortex. If we have to do more than one test, or if we have to do all the tests, then we start with pattern ERG. It's a binocular recording and dilatation is not required. Once we do this, then we dilate the pupil fully and dark adapt for about 30 minutes. And after that, we do scotopic ERG. Then again, we light adapt the eye for 15 minutes and do a photopic ERG. There are different waves that you will be shown in subsequent talks in ERG. Basically, the A, B, and C wave. The A wave is the negative component of photoreceptors. The B wave is the positive deflection, which is produced by the Muller and bipolar cells. Then there is a C wave, which is a positive deflection following the B wave, and it tells us about the basal portion of the RPE. And there are oscillatory potentials, which are positive wavelets on the ascending limb of the B wave, and it tells us about it is produced by the amacrine cells. So this is a diagrammatic representation of the same. Here you can see the A wave is produced by the receptors, photoreceptors. B wave is by the bipolar cells. Then C wave is the Muller cells, the RPE layer. And there is a D wave that is also produced by the bipolar cells, and oscillatory potentials by amacrine cells. These. In full field electroretinogram, it is a mass electrical response of the retina to photopic stimulation, that photoreceptors to the inner plexiform layer. And pattern electroretinogram, we measure the central retinal and ganglion cell function. Stimulation is by reversing black and white checkerboard. It differentiates optic nerve and macular function. It is recorded using DTL electrodes. Electrooculogram checks the change in the electrical potential between the cornea and the ocular fundus, the outer retina and RPE. It is recorded during successive periods of dark and light adaptation. And VEP, it tells us about the electrical signals generated at visual cortex in response to visual stimulation. It assesses the integrity of visual pathway and reflects the activity of central visual field. In multifocal electrogram, it tells us about it takes the simultaneous recording of focal retinal responses. It offers direct, objective, and topographical mapping. Central 30 to 40 degree of retinal function is assessed. It is a cone-driven response, and fovea, parafovea, and near peripheral photopic retina function can be evaluated. ERG is recorded by measuring the potential difference between electrodes, one of which may be a contact lens electrode. There is a reference electrode which are applied close to the eye near canthus, and the ground electrode is applied to the forehead. This is a comprehensive chart that tells us about the different conditions and different requirements for each test, whether refractive correction is needed or not. The visual acuity is important, like in full field ERG, the visual acuity is not important. Then pupil size, in some of the tests it is undilated and some of the tests are done under dilated conditions. Then the test distance also, all the tests, most of the tests are done at 30 centimeters, but pattern VEP is done at 1 meter distance and pattern ERG is done at 1 meter distance. Fixation is very important in ERG, is important, very important in multifocal ERG, EOG, but it is not important in VEP, full field VEP. And similarly, whether one eye is to be tested or both eyes. So this is a very comprehensive chart, and refractive correction also you can see. So it is important while doing or ordering for electrophysiological tests, an examination of patients before tests are ordered.
Please conclude, Dr. Vibhuti.
Thank you very much, sir.
Thank you. Thank you. Well, on time. Our next speaker is Dr. Rahul Prasad. He'll be talking about the electrodes on our.
Very good morning, sir. And at the onset, I would like to thank the AIOS Scientific Committee for giving us the opportunity to present our instruction course on ERG. Thank you, sir, Vibhuti sir, for giving us a splendid introduction to what ERG means and the components of ERG. My job today is to give an understanding of what machines that we use and the electrodes that are used for ERG. So to record in ERG, we must have an understanding of its basic technology that has to be used and the clinical protocol to be followed. The basic technology includes information about the electrode, what happens when the eye is stimulated by the light, and finally electronic recording devices which record the impulses. The clinical protocol includes how to prepare the patient, the access standard for the ERG, and finally the analysis and the reporting of the ERG. Coming to the first part, that is the electrodes. Now there are three types of electrodes that are used in ERG. They are the active, reference, and the ground electrode. The stability of these electrodes are maintained by a good connection. Now good connection also causes a decrease in the impedance, and less of impedance would mean less noise. And if the impedance is more, that leads to a wrong reading. Now, the cleanliness has to be done, has to be preserved for the electrode because it avoids infection and also it decreases the impedance. For a good recording by an active electrode, we have to ensure a use of a non-irritating, non-allergenic, ionic, conductive, and a relative non-viscous solution. It should have a very good ocular contact to ensure proper electrode impedance, and we should define both normal values and variability for our own laboratories. Now, the different types of electrode that we can use are, the active electrode that we can use are the conductive fibers, foils, conjunctival loop electrodes, and the contact lens electrode. The contact lens electrode are centrally transparent with an optical opening, just works like a lid speculum. It gives the best recording, and the recording is stable even with the highest amplitude. The types of electrode include the skin electrode. They are mainly used in children. The corneal ERG electrode, which can be monopolar or bipolar. The DTL electrodes that are the most commonly used electrode, and the gold foil electrodes. The second type is the reference electrodes. Now they are incorporated into a contact lens speculum assembly where you can, when you are using a bipolar electrode, such as the Burian electrode for stable configuration electrically. These electrodes can be placed near the orbital rim or the ear lobe or even on the forehead. The third type of electrode that are used in ERG are the ground electrodes. They are a separate screen electrode which are attached to an indifferent point and are connected to the ground. Typical location for attachment of these electrodes are either forehead or near the ear. Now, understanding what actual electrical impulse is captured. So there are two words, two letters, A and R. The A represents the capture action potential that is captured by the active electrode, which constitutes of both the actual action potential and the impedance. The R constitutes the impedance that is captured by the reference electrode. Now, if we subtract, then we get the actual electrical impulse. Now coming to some specific types of electrode. The first is the jet electrodes, ERG jet electrodes. These are disposable monopolar contact lens electrode, gold foil electrode or polymethylgrade with lead wires. It has got an ease of insertion. However, movement of lens during recording and absence of lid speculum can contribute to the variability of the recording. It reduces the possibility of eye infection. The disadvantage is the gold plate etches off with time. The second variety is the Burian Allen electrode. These are bipolar reusable contact lens electrode with a built-in speculum and lead wire. It is customizable to various sizes, ideal for testing infants. The reference electrodes are built into the electrodes. The PMA shows variable degree of blurring, so not suitable for recording pattern ERG where the image clarity is vital. They are basically used for full field ERG, but remember, they are very costly in nature. The most commonly used is the DTL plus microconductive thread electrode. These are conductive threads, almost 50 microns, floats on the corneal film surface. It has got a negligible mass, low cost, and is disposable, convenient to use, and it gives a very clear image. There's no interference with pupil or optics. It gives a very reliable ERG reading and is very well tolerated by the children. Then is the gold foil electrode, which are useful when we can't use a contact lens electrode or when you don't want to anesthetize the cornea. The ERG amplitude will be substantially affected by these electrodes, and it requires an adapter. Now the color coding, if we just see the adapter wires and the electrode wires are, the active electrode are usually red in color, the reference electrode are usually blue in color, and the ground electrode are usually black in color. Now, what kind of gel that we use? It is the skin part is usually clean for the reference and the ground electrode. The cup of electrodes are filled with gel and are attached for better conductivity. Now, adapters usually are one channel and are two channel adapters. The test for one eye is usually done by one channel, and those for two eyes are usually done by two channel adapters. After electrodes, the second important part is the machine. The machine consists of a computer monitor which tells at which stage the investigation we are in. It also guides us through the test, and there are two types of stimulation machines. One is the pattern stimulation and another is the flash stimulation. Now this is a side view to show the electrodes that are placed on the child. And this picture shows how one eye is closed for multifocal ERG and the electrodes are placed. The movable chin rest has to be placed in front of the monitor. The chin rest with monitor and the fixation point can be seen in this particular slide. The monitor displays random pattern for multifocal ERG. Then after that, for flash, we move the chin rest is removed to the Ganzerfeld ball. This actually gives us a closer view of baby flash for babies and unconscious patients. Now this is what a Ganzerfeld ball looks like. After the test, the movable chin rest is attached to other place when it is not required. These are this slide shows the different electrode put in different places for in different tests. So recording the ERG, one has to explain to the patient the test procedure. The pupil should be dilated, the patient dark adapted in a dark room with an eye patch, and an electrodes attached with a dim red light in the room, and then we start the test. Attach the electrode and follow the guidelines coming on the computer screen. Safety informations have to be kept in mind. For the machine, a printer or external USB hard drive should be connected via Wi-Fi, and if it gets disconnected, should not be tried to connect while the test is going on. The automatic updates should be deactivated, dark room should be properly lit, and disconnect the power supply before any cleaning or repair. It should not be connected to by an extension cord, and always use an external drive to have a regular backup. A password should be there to protect the patient's data. For the patient, electrode should not be attached to the damaged skin. The patient should be explained about the procedure, and waste should be disposed in the household waste. Thank you, sir.
Thank you, Dr. Raul. It was quite comprehensive, and we have learned the basic of the machine and the electrodes. The most commonly used electrodes remains the DLT1. Next is multifocal full-field ERG.
Our chief instructor,
The other one. इसके ऊपर वाला. Yeah.
Dr. BP Kashyap,
Yeah,
our
yeah.
chief instructor, will be talking about full field ERG and multifocal ERG.
Yeah, good morning. So most of the basic things are covered by our previous speakers. So what precautions do you take while doing a full field ERG, because the patient has to be kept in the dark for some time. So please do not use indirect ophthalmoscopy or indirect lasers or do anything which gives light to the in the patient's eye. And you have to dilate the pupil fully, and if you can measure the pupil dilatation, it's good. And adapt the patient for at least 30 minutes. If you have done some procedure on the patient's eye, you have to wait for a little longer. We sometimes have to wait even for 1 hour. The DLT wire should not be touching the conjunctiva, should be touching the conjunctiva only, and in the lower fornix, it should be in a proximity with the cornea, but cornea should be taken care. And these electrodes have been told by Dr. Rahul. So this is the same picture here. So now the test and the stimulations. We do the test in scotopic condition and photopic conditions. In dark adaptation, there are, the 0.01 ERG is there, 3 ERG, 10 ERG, and oscillatory potentials are there. And in photopic, it's light adapted, that is 3 ERG, and light adapted in flickers, 30 hertz flickers. So now, what happens in 0.01 ERG? The light is very, very minimal, and the interval between the flashes are approximately 2 seconds, and the source of the wave is from the rod system. And if you slightly increase the intensity of the light to 3 candela lights, and the interval also increases to 10 seconds, the A wave further deepens down and is more prominent. The wave is mainly from the rods, but has a slight contribution from the cones also whether you see the positive one. If it is further increase to 10 candela and the interval remains the same, you will see the waves a little better. In oscillatory potentials, it is the amacrine cells, and you will see the waves. In light adapted, you make the patient to stay in the light for a little time, let's say 10 to 15 minutes time. A single flash in a background rod saturating light is given to the patient, and it's a standard flash, and the interval between this flash, the stimulus is 0.5 seconds. The A wave comes from the photoreceptors plus a little bit of bipolar cell. B stands for bipolar. B wave comes from bipolar cells. And in 30 hertz flickers, there is a standard flash, and the stimulus is 30 stimuli per second. It suppresses the rod system. Before there is a distinguishing of the rod system, the light system, the bipolar system. They are kept stimulated. But then if you are doing this test, then first few seconds recording should be discarded. It's a very, very sensitive test to if you are going to measure the cone function. So these are the waves that you get in 0.01, 3 ERG, 10 ERG, dark adaptation with oscillatory potential. So these are the kinds of waves you get it. A wave is a negative wave, originates from the photoreceptors. B wave, positive wave, arises from the Muller cells, the bipolar cells. and you must have at least damage of more than 20% to get some ERG changes. This will be repeated again because I want to make you understand that if you suspect certain disease, then you have to go for that test. Suppose because of the the blood supply of the posterior segment and the inner part are different. Let's say if there is some patient has if you suspect some ciliary blood vessels, so the outer part of the retina will be damaged. If you suspect some occlusion of the retinal blood vessels, the central retinal artery or central retinal vein occlusion, then you can expect the damage of the cones and bipolar cells.
जहाँ तुम्हारी ड्यूटी है
So, in full-field ERG, what happens is there are many cells, many photoreceptors from the periphery, and those many receptors from the periphery, they merge to some bipolar cells, and all those bipolar cells, they merge to one ganglion cells layer, and then ultimately you get the connection to the optic nerve. But in macula, what happens? The cones, etc., is very, very packed, and it's almost kind of 1:1. One photoreceptor gets connected to one bipolar cells, to one ganglion cells, so this is very, very sensitive. So these are normal responses, and when we report the normal and the abnormal one. So in this case, it is both the eyes are normal.
हम डाल देंगे
In this case, there is a ischemic CRVO. If there is CRVO, what do we expect? We expect the rods and cones. We expect the posterior part of the retina to be normal. It is the inner part which is suspected to be having some problem. So in this case, you will see that this 30 hertz flicker has reduced in the lower right hand side diagram. If the cone dystrophy, it's all flat. There is no flicker sign at all. And if the negative ERG is very, very important in cases if you feel that the patient is suffering from CRVO. So you can, if it is a negative ERG, it means the patient's the prognosis is poor. And in this case, you will see that the flicker hearts are normal. So what is negative ERG? It's just one of the very talked about subject. So the B wave is smaller than the A wave, and it has got a diagnostic value for the central retinal vein occlusion, proliferative diabetic retinopathy, endophthalmitis, congenital stationary night blindness, and juvenile retinoschisis. So when do we suggest a full-field ERG? Apart from all those other things, the most important is the retinal ischemia, that is diabetic vascular diseases, retinal vein and artery occlusions, and other most important are abnormal result of the visual field test. You do not expect anything, and you see that there is some problem in the patient's vision. So when do we suggest a full-field ERG? Opacity in the media is very important. Suppose if there is a corneal opacity and you have put the patient for the corneal grafting. If there is a patient has got a mature cataract and with a history of trauma, you don't know the prognosis, you do the full-field ERG, it will tell you. If there is a dense vitreous hemorrhage, it will help, and monitoring the health, that is if the patient is taking hydroquinone or other toxicity. Now, if you are doing a full-field ERG, the multifocal ERG should be done, and it is one of the recent advances, and it takes care of 36 to 40 degree central retinal function. And it is cone-driven responses. It tells you the health of the fovea and parafoveal. What is the difference between the full-field ERG and multifocal ERG? It's the method of stimulation. That was by the flashlight, and this is by the CRT. And it's a scaled hexagonal array stimulations. And there are 61 to 103 hexagonal arrays, and they flicker between the two binary states, black and white, and it's predetermined. So it provides high resolution spatial and temporal information from the retina, and frame changes for every 13.33 seconds, and CRT device is there to deliver the multifocal stimulus. So this is how it looks like. It's predetermined. There is 103 hexagonal arrays, and it is black and white. So clinical protocol is, if you're doing multifocal ERG, the people should be dilated. All those distance is 33, fixation is essential, full correction of the refraction is there, should be there. You have to correct the refractive error and then put the patient, for the examination. And it takes around about 50 to 60 minutes. And the data reporting is in array map and topographic map. So the response is obtained from the 6th zone of the macula and fovea. So in a Stargardt's disease, it's very easy to interpret it. You see, in this case, the central zone is gone. It's black, means no vision, little less, it's blue and all. So what happens is, in all these cases of the multifocal ERG, there's a tuff that is N1, and then the positive peak of P1. So we take the implicit time and the amplitude of the waves. So in macula, the two types of ERG functions, that is multifocal ERG, which is cone sensor function of the macula, and the pattern ERG that takes care of the macula to the ganglion cell layers. If the patient has got some receptors problem, the multifocal ERG is essential, and in pattern ERG, the N1, P1 wave will be lower, and if there is something wrong with if you suspect the glaucoma, the patient will have a less of P10. So it is useful for the macular dystrophies, central serous retinopathy, drug toxicity, and inflammatory conditions. These are very important slides, and at the cost of a repetition, you must remember this chart, and then if you are doing ERG, you should know what waves to see. In full-field ERG, you have to see the A, B, and C waves. If you're doing flash VP, you have to observe the N2 and P2. That occurs at 90 milliseconds and 120 milliseconds. P2 should be 100 plus minus 10. And amplitude should be more than 10 microvolts. So if you see the flash VP, you look for this. And when you're seeing the EOG, the add-on ratio should be less than 1.65. If you're doing pattern ERG, you look for the N35, P50, and N95. P50 reflects the macular function, and N95 reflects the ganglion cell functions. So if you have certain diseases like retinal dystrophy, what all should be done is in the chart. That is EOG, whether you'll do pattern ERG, whether you'll do flash ERG, flash VP. So sometimes one test is complementary to the other. So this is a normal report of a multifocal ERG. Thank you so much. If you have any question.
So thank you so much. Dr. BP Kashyap is our chief instructor of this course. And our next speaker is pattern ERG, Dr. Soumya. Dr. Soumya has done her senior residency in VR surgery from RP Center AIMS. PG also from AIMS.
Good morning, everyone. I'll be talking about pattern ERG. So, when does pattern ERG comes into role? So, when we are not able to distinguish that the cause of vision loss is macular or related to optic nerve, we go in for pattern ERG. So, there are cases where clinically the fundus appears normal and we are not able to distinguish the macular or the optic nerve causes, like in cases of subtle posterior scleritis. Those cases, we can do a pattern ERG and come to a conclusion. So there was a study by Dr. Holder et al. Where they showed the conclusion of the study was basically that the P100 wave of VP is decreased both in macular as well as optic nerve causes. However, the P50 wave of pattern ERG is selective for macular causes. So, this is a case where a child who had low vision in the left eye presented to us. So first pattern VP was done, right eye was normal. In the left eye, the P100 wave was, amplitude of P100 wave was decreased. The child was offered pattern ERG, and in pattern ERG, the P50 wave was also diminished, indicating that the cause of vision loss was macular. Further investigations revealed that the child was suffering from posterior scleritis. So pattern ERG basically helps us to narrow down to macular cause or optic nerve cause of vision loss. In a pattern ERG, the pattern ERG actually assesses the central retinal response. We give a stimulus to the patient, which is a checkerboard. It is temporarily alternating pattern, means that the black will eventually turn into white and the white check eventually turns into black. The stimulus subjects a field of 15 degree to the eye. This is how the screen looked like, and the patient binocularly focuses to the red cross. The net retinal illumination remains constant. It's only a redistribution of pattern of light and dark areas. It is iso-illuminant. Again, the net retinal illumination is constant. So in pattern ERG, we talk of N waves and P waves, unlike A waves and B waves of full field and multi-field ERG. To remember, P50 wave is by the photoreceptors, so any problem in the photoreceptors will affect the P50 wave, and any problem with ganglion cells will affect the N95 wave. So macular dysfunction, the amplitude of P50 will be decreased, and if N95 wave is affected, that means the ganglion cell and eventually the optic nerve is affected. There are two types of pattern ERG. The most commonly used is transient pattern ERG. So while conducting the test, the patient is asked to sit at 1 meter distance. The patient is light adapted. We don't need dilatation in case of pattern ERG, as already been told. Fixation is very important. The patient sits at 1 meter with proper refraction. This is again about the stimulus. It is of high contrast. That means the white and the black checkboard has a contrast of more than 90%. The reversal rate is 4 per second. The test is offered binocularly, but even if we need to test uniocular, it can be done by occluding one eye. Electrodes has been talked about in detail. I'll again tell that the cleaning of electrodes is very important. When we place the electrodes, the machine gives us the impedance. The electrodes should have low impedance, and when it is less than 5, the machine gives a green signal. That means the electrodes are working good. To repeat, there are 2 elective electrodes, 2 reference, and 1 ground electrode. There are channels, channel 1 and channel 2. By convention, right eye is always channel 1, left eye is channel 2. In pattern ERG, we use DTL electrodes. So they are placed at medial and lateral canthus, and the wire-like thing goes through the eye, touching the bulbar conjunctiva. This is the magnified photo of the same. This electrode is going through the bulbar conjunctiva. We need gel before placing the electrodes. So there is a gel that has to be applied at the skin, and another gel applied on the electrodes. So this is how the machine shows us. We select the patient, then we'll select pattern ERG. So this is how the waves are coming. Now, because the waves, this one. Now, because these waves are abnormal, we need to look what is the problem happening. So here the problem was that the microvolt was 50 microvolt, which was very high. So decreasing the microvolt is decreased to 5 microvolt. Now this is what I was talking about, the impedance. When we place all the electrodes, the impedance, when it is low, the machine gives a green signal. When it is red, that means the impedance is high and the readings won't come correct. So in that case, we'll have to remove the electrodes, clean it apply the gel properly and then replace it. So after replacing, again, when the impedance is low, the machine gives a green signal and we can proceed with the reading. So this is in between the test. We see that left eye is doing well, the waves are normal. The right eye, the waves aren't coming normal. So this could be pathological or this could be a test error also. So we go back and check the impedance again. There was a problem with the impedance and then we lowered the impedance of the electrode and the test came normal. So while reporting, we see P50 wave and N90 wave. We see the amplitude of both the waves. We see latency of both the waves. And it's ideal that every lab should have their own normal values. This is how a report comes in, a right eye and the left eye, the amplitude of both the waves and latency of both the waves. So to remember, P50 indicates macular function. So in cases where the problem lies in the macula, the P50 wave will be affected and will be abnormal. In cases where the problem lies with the ganglion cell, the N95 waves will be affected. Cases like glaucoma, early glaucoma are easily picked up by pattern ERG where N95 wave is affected. It is always advisable that pattern ERG is combined with pattern VEP so that you come to a conclusion that your pathology lies at what point. Just to emphasize, pattern ERG is sometimes detectable in no PL eyes also, so we have to be aware of that. We can also distinguish that the problem is at the central macula or the peripheral macula while changing the degree of the stimulus. As I said previously, the checkerboard which we were using was 15 degree. If we use 30 degree, we can check peripheral macular function as well. So uses is early glaucoma detection where N95 will be affected, and we can monitor drug toxicity also. There are drugs that affect the macula, there are drugs that affect optic nerve. So if we monitor P50 wave, macular toxic drugs can be checked for their improvement, and if N95 wave is affected, neurotoxic drugs can be monitored. Thank you.
Thank you, Dr. Soumya. Next talk is electrooculogram by myself. I am Dr. Bharti Kashyap, Director Kashyap Memorial Eye Hospital, Ranchi. Good morning, everyone. My topic is tips on electrooculogram. Who is credited with the first description of electrooculogram? It was named by Elwin Mark, and the clinical application was described by Geoffrey Arden. Initially, it will look boring, but later on, I am going to discuss the clinical application of EOG. The principle behind EOG is the test to measure standing potential of the eye, approximately 5 mV, indirectly transepithelial potential that exists between the cornea and the Bruch's membrane at the back of the eye. Normal light peak requires normally functioning photoreceptors in contact with the normal functioning RPE. It tests RPE layer and the outer retina. Physiology is 15 minutes periods of dark adaptation. There is a fall in the recorded standing potential, typically reaching a minimum at 10 minutes. This is referred as dark trough, TT. Following light onset, there is an increase in TEP of the RPE, producing the light rise of EOG. This is the physiology. The light rise is ultimately the result of, should I discuss physiology or should I fast forward? This is the prerequisite and special instructions. Head position should be stable, eye movement only in horizontal direction, never anticipate and move prior. Increase illumination in case of non-dilating pupil, avoid any bright light procedure before EOG. The prerequisite is pupil should be dilated, pre-test 20 minutes normal room light adaptation, full extraocular motility, good visual acuity, refraction correction not needed, impedance should be less than 5 kilo ohm. How EOG is performed. The stimulator is ganjophil dome. You can see here the fixation target is two LED lights, 15 degree left and right of the central light. Bright during light adaptation and minimum brightness in the dark. The pupil should be dilated before testing. After suitable skin preparation, recording electrodes should be placed close to the canthi of each eye. For the dark phase, total darkness should be maintained for 15 minutes except for the dim fixation light. For the light phase, a gauge field background light of 100 photopic candela square meter should be turned on. Continue the recording for 10 seconds out of every minute in each phase. Active and reference electrode, inner and outer canthi ground electrode forehead and impedance should be less than 5 kilo ohm. You can see the gold cup electrodes, black is ground electrode, blue is reference and red is active. A patient has to move his eyes to LED with single sweep with head fixed. Sackets are recorded 10-15 seconds per minute, 45-50 seconds rest. Measure 15 minutes in dark, 15 minutes in light. Ardent ratio is normal is 2:1, light peak upon dark trough. And if it is less than 1.7, it is abnormal. And basically it is used for diagnosing Best disease and the different types of bestrophinopathies. So the parameters which should be included in EOG report is LP by DT ratio, DT amplitude, implicit time, time from the start of light phase to light peak, type of adapting, light source, pupil size, and also note any difficulty encountered during testing which may affect the confidence in the results such as inconsistent eye movement, etc. The reliable EOG is just presence of a square and regularly placed wave forms. If waves are not that proper, that means either patient is not fixating properly or electrode is moving. Light and dark values are taken in respective adaptation period, typically 12 minutes for dark trough and 25 to 26 minutes for light peak. Background illumination 100 candelas per square meter. This is the relationship. The normal light rise in EOG requires a normal RPE and good photoreceptor function. As the light rise depends on the photoreceptor function also, patients with abnormal rod function will have a corresponding reduction in the light rise, thus mirroring the extent of rod photoreceptor damage. If ERG is absolutely negative, then EOG would be absolutely negative too. Some photoreceptor action is must to have an EOG reading. So we recommend always to do ERG and EOG together. In presence of good rod function in ERG, a reduction in the light rise in EOG is suggestive of abnormality located in the RP, that is Best disease. Clinical applications. The most common use of EOG is to confirm vitelliform macular dystrophy. Patients with Best disease and some patients with adult vitelliform dystrophy have normal ERG but abnormal EOG. In this case, you can see EOG is abnormal, Ardent ratio is 1.33. So this is the chart. This chart is very important. So the first one is dominant best. The second one, which is autosomal recessive bestrophinopathy, is recessive best. And the third one is the important adult onset macular dystrophy. So in the dominant best, EOG is reduced and ERG is normal. In recessive best, that is the second one, autosomal recessive bestrophinopathy, both ERG and EOG, I have written mildly, but it is not mild, both are reduced, EOG and ERG. And third one, adult onset, both are normal. So this EOG is abnormal irrespective of the stage of Best vitelliform dystrophy. This is a case of unilateral clinical Best vitelliform dystrophy having a suboptimal Ardent ratio in both the eyes. In the eye where there is normal, but the other eye has a Best disease, the normal eye also will show reduced Ardent ratio. And suppose if a child comes and you are getting, it is very difficult to perform, then test the parents, both the parents. One parent will be carrier and surely exhibit abnormal EOG. This is the another case, 11-year-old male, blurred vision, BCVA 6/9. You can see this is a autosomal dominant Best disease. You can see the deposits, and this is the OCT. This is the serous RD. And you can see here, ERG is normal and EOG is abnormal. This is the second case. The 10-year-old male born out of a consanguineous marriage, blurred vision, BCVA 6/18 partial, hypermetropic refraction, narrow angles. Now you see, the subretinal lipofuscin deposits predominantly outside the macula, accumulation of fluid within, beneath the neurosensory retina and also within. This is autosomal recessive bestrophinopathy, that is called recessive Best. And in recessive Best, both ERG and EOG, you can see both are reduced. So this is the fast oscillation EOG. It has recently come in vogue. So It can be used for detection of severity of macular functional disturbance and predicting the visual outcome for CRVO. So that's all. I discussed the physiology and I discussed the clinical applications with example of few cases. I hope you all understood it. Thank you. So the next speaker is Dr. Pallavi. Dr. Pallavi is a retina consultant in Ranchi-based Kashyap Memorial Eye Hospital. She's talking about BP, and I have to introduce the Dr. Vibhuti Bhushan. He is the co-instructor. He is a retina consultant in Vishnu Netralaya, Jamshedpur. And Dr. Rahul Prasad is the retina consultant in the largest government sector medical college of Jharkhand, that is Rio RIMS. So you have already heard them now.
Good morning, everyone. I'll be talking about VEP, Visual Evoked Potential. So electrical signals are generated at visual cortex in response to visual stimulation. Visual stimulation is carried to occipital cortex from retina via optic nerve, optic chiasma, and optic radiation. The peripheral retinal projections are within calcarine fissure. Central retinal projections are taken to occipital lobe, and foveal projections are magnified at the cortex. The indications for VEP is optic neuritis, multiple sclerosis, optic atrophy, hereditary optic neuropathies, toxic neuropathy, traumatic brain injury, compressive optic neuropathy, glaucoma, amblyopia. Additionally, it is helpful in unexplained visual loss, malingering, pre-surgical evaluation, and measuring visual acuity in non-responsive subjects. The requirements for the test is 3 electrodes, active, reference, and ground electrodes. The impedance is less than 5 kilo ohms. The active and reference electrode impedance difference should be less than 20%. So the head is divided, it's an international classification where head is divided from nasion to inion based on 10-20 rule. So these electrodes are placed at, the reference electrode is placed at FZ, ground electrode is placed at CZ, and active electrode is placed at OZ. Z signifies the midline structures. This is the recording arm. So the VEP depends on different kinds of stimuli. So one is flash VEP, one is pattern VEP. The flash VEP is done by Gansfield stimulator and pattern VEP by CRT monitor. The pattern VEP is most commonly done with patients with good visual acuity. So the requirements is the patient is light adapted, seated at 1 meter with full refractive correction. The patient is undilated. The test is performed monoocularly. The other eye is patched. And the requirement is the checkerboard pattern. The pattern is reversed, that is that black to white and white to black. There are different checker sizes, 60 minutes and 15 minutes. The luminance is constant and the contrast used is high. Flash VEP is done, the indication for pattern and flash VEP is same, but the flash VEP is done in the patients with poor visual acuity. The patient is light adapted, but the room is dimly illuminated. This is also performed monoocularly, other eye is patched. The field size is more than 20 degree in flash VEP, at least 1 flash per second, that is 1 hertz. The flash intensity is 1.5 to 3 candela per meter square, and background intensity is 15 to 30 candela per meter square. I'll be talking about pattern onset and offset later on. So the pattern VEP is used for optic neuropathy, flash VEP for poor optics, poor cooperation, and poor vision, and pattern onset and offset is used for nystagmus, malingering, and amblyopia. So now let's come to pattern VEP. The checkboard stimuli is used. The pattern is reversed from white to black, black to white checkerboard pattern. We should also keep in mind about the artifact, that is blinking of eye. It should be lesser. The average number of tests is 64 per test. The test results is done at least twice. Every test is repeated twice. In infants and uncooperative patients, the number of tests can be reduced. So this is how the patient is seated and looks at the pattern. The checks subtend an angle of the angle of 15 minutes of arc are best for testing foveal vision. The checks of 60 minutes are superior in evaluating the parafoveal function. Therefore, using more than one check size increases the diagnostic yield. If the resulting VEP using the 16-minute check is poorly formed, the retest using an even larger check size is used. So these are the waveforms of pattern VEP, 3 waves, N1, N2 and P. So P is the positive and most important wave. The two things are important, latency and amplitude. The amplitude is calculated from the trough of the N till the peak of the P wave. It is normally more than 500 microvolts and the latency period is on an average 100 milliseconds. This is how the report is given to the patient. Now let's come to some examples. This is a normal waveform. In traumatic optic neuropathy, there is a delayed implicit time and there is reduced amplitude in left eye, whereas right eye shows normal waveform. In AION, there is implicit time is nearly normal. There is reduced amplitude and a wide waveform. In optic atrophy, there is no signal recorded in the affected eye. The other eye shows normal waveform. In neurofibromatosis, that is, there are optic gliomas. So this shows slowing of VP components in both optic nerve. In ethambutol toxicity, there is slowing of P100 peak times. Now let's talk about pattern onset and offset. In this, the pattern is on for 200 millisecond and it is off for 400 millisecond. When the pattern is off, the background illuminance is the same. This is also done with two sizes, 60 minutes and 15 minutes check. The pattern onset or pattern flash stimuli produces a more robust VP than does pattern reversal in central 30 degree. So this is the comparison between the pattern onset offset waveform and the pattern reversal waveform. So pattern reversal stimuli usually exacerbates the nystagmus, interfering with the ability of eye to maintain foveal fixation. That's why this pattern onset and offset is important for patient with nystagmus. And this pattern onset offset is less sensitive to poor fixation. That's why it is also good for testing the patients with malingering. It is also useful in monitoring amblyopia. These are the waveforms of pattern onset and offset. There are 3 waves. The C2 is the most important one. Normal latency is 100 to 120 milliseconds. The indications for flash VP is uncooperative patient, unconscious patient, media opacities. It prognosticates the eye with poor vision before planning of surgery and monitoring visual function of babies. These are the waveforms of flash VP. There are 4 waves. The P2 is the most important one. Latency is 100 to 120 and N2 P2 amplitude is more than 10 microvolts. This is how the report is given. Just a little note on sweep VEP. It is used in infants, suspected malingers and disabled subjects. The visual acuity can be calculated in logmar units. This is how the report is. And multifocal VEP, it's not used that commonly. It is an objective assessment of visual field and perimetry used for glaucoma and retrochiasmal dysfunctions. These are the 3 waveforms, the pattern VP, flash VP and pattern onset offset VP. Okay, thank you.
Thank you so much. Now the session of electrophysiology, which appears boring, but it is actually, once you come to know about it, it is very, very interesting, and it really, really helps to resolve the complicated, to reach the diagnosis of complicated retinal and optic nerve diseases. So thank you very much for attending our course, all of you.